Yesterday was my last day on psychiatry rotation, so I thought it was time for another reflection video. Let's start with how my day looks like on psychiatry. I usually get to the hospital by around 8 a.m. And I go to the nursing station and get a personal safety device. It's a clip-on device with a button that if you press for a few seconds, it sets off an alarm. We use it in situations where patients are being aggressive. So we always carry that around when we have to see patients. And then I print off a daily list with all of our patient names, their history, what they're here for in the hospital, and what we need to do for each patient on that day. And if there are any new admissions, I try to review the patient chart and get started on a new consult, learning about their history of presenting illness, past psychiatric or medical history, their medications, family history, and so on. And then for our team, we go to rounds at 9:45. So it's a conference room where we have our psychiatry team, patient care coordinator, the social worker, pharmacists, nurses, and we get updates on how patients did overnight. And if we need to liaise with allied healthcare workers for anything like figuring out housing, their finances, where they're gonna go when they get discharged, if we need to refer them to the community, we do that during rounds so that everyone's on the same page. Afterwards, our team gathers in a room and we go through the list again, and then we try to schedule the day during that time. For me as a medical student, I usually saw 2 to 3 patients on follow-up, checking in how they're doing and seeing if there's any change in their mental status and if they're tolerating their medications well. So I do that for most of the day, and whenever our supervising psychiatrist is available, we try to see those new patients together and do an interview, and it's during that time that we can establish the initial mental status exam. On mental status exam, it includes appearance, such as what the patient is wearing, how they're appearing, are they disheveled, do they have good hygiene, what ethnicity, and do they appear their stated age. There's behavior, so are they cooperative, are they pleasant or hostile, any abnormal movements like psychomotor abnormalities, do they maintain good eye contact, are they aggressive, and then we comment on speech. Is it normal or abnormal rate, rhythm, tone? Is it appropriate quantity? Are they excessively talkative or do they not talk much? And is there latency in their speech? Then we assess mood and affect. So mood is what the patient says, like I'm feeling sad, I'm feeling happy. And affect is what we can observe. Do they appear downcast, angry, euthymic, so normal emotions with normal range? And we see whether affect is consistent with mood. And then the thought process. So is it linear and goal directed, or is it tangential? Are they going off on a different topic, or are they circumstantial? Are they being over-inclusive of details? And thought content. So what are they telling us about? What's on their mind? Do they have any thoughts of harming themselves or other people? Are they preoccupied with certain thoughts? And then perception, so do they have auditory or visual hallucination? Are they responding to internal stimuli? And then cognition, so do they have normal cognition? For older adults, we can administer MOCA to assess cognition formally. And then insight, do they understand what's going on? And judgment, do they act appropriately? Are they compliant and cooperative, or are they making questionable decisions or doing questionable things? And one tip I got from a resident is to think of it as describing someone to another person who doesn't know this person at all. So you want to be descriptive. You want them to be able to picture who this person might be like. I was in inpatient units, so the bread and butter might be different in an outpatient setting or like a high acuity setting. So the patients I worked with were either brought to the hospital involuntarily by police, and then they were certified and involuntarily admitted because they were at risk for themselves, other people, and at risk for deterioration. Or there were patients who came to the hospital voluntarily because, for example, they had suicidal ideation and wanted to get help. The conditions I saw most commonly were schizophrenia, bipolar type 1 during a manic episode, depression with active suicidal ideation, and some cluster B traits, especially borderline personality disorder. And now I want to talk about my own personal reflections on what I learned and how I felt during psychiatry rotation. So, as some of you might know, I was coming off of surgical rotations into psychiatry, and the transition was interesting because in surgery I was used to being efficient and writing notes that are no more than a few sentences and mostly procedural, to psychiatry, which is very detail oriented. It's based on conversations with patients. There's a lot of liaising with allied healthcare workers and approaching their management from this biopsychosocial aspects, so more comprehensive. The initial transition was rough, but once I got used to it, I started to really enjoy it. First of all, I love hearing patient stories. Even the patients with the same diagnosis, for example, schizophrenia, everyone presents with their own unique story, and that makes it really interesting. I remember when I was in anesthesia rotation, I just loved doing the pre-anesthetic assessment and asking them questions, what happened. So I think I'm just naturally really inclined to asking questions and hearing their stories. And when these patients that get discharged, usually they're connected with the mental health team and community psychiatrist, and it seems like there's an aspect of relationship building over a long period of time, and that's something I like as well. I found that the residents seemed really happy and satisfied with their job, and residency can be a tough period for anyone in any specialty, but I think that since it's a specialty treating mental illnesses, there's a huge emphasis on mental health for residents and other trainees as well. So I worked with such wonderful residents who always asked me how I was doing and told me to get lunch and go home at a reasonable time. And even residents from another team came by to check on me to see how I was doing. So it was a very nice and friendly environment. Everyone's looking out for each other. And this is a side story, but there was the World Cup during my rotation, and we actually watched it together over lunch break, and we had Korean fried chicken, and it was so much fun. And then towards the end of the rotation, my staff brought all the residents, myself, and some of the allied healthcare workers out for dinner, and we had K-barbecue. So I just have so many fond memories, and it's so great that we have room to share our personal lives and build relationships outside of work context. I think psychiatry also had a positive influence on my own life as well. I'm being more cognizant of how I'm communicating with people around me, and I'm looking at my own relationships in a more mindful way. So it's really cool that work and life can have positive influence on one another. And yesterday on my last day, I had a really nice conversation with my staff, and something he said really struck me, which is that in psychiatry, the way you talk to your patients and convey empathy is a form of art, and that forms the bulk of treatment. And medications are helping, but that's not everything. So it seems like this specialty is multidimensional in that you have the core relationship between you and the patient. You have medications to help with the progress, and you have the multidisciplinary team who are looking after the social aspect, housing and finances and so on. If you guys watched my pediatrics rotation video, you guys might know how much I enjoyed the multidisciplinary care aspect. I loved family meetings and being able to work with other healthcare professionals. So psychiatry definitely had that. And in terms of downsides, I don't have that many, but in inpatient psychiatry, patients get discharged when they're not in acute risk, so they're not well 100% before they go home, which is different process compared to, say, general surgery, where you do the surgery and they have bowel movements and they're good to go home. Since some of the patients are admitted involuntarily under the Mental Health Act, they can be really insistent on being discharged even though they're not well, and they might lack the insight to even realize that they're not well enough to go home. So patients might not always be on your side. You sometimes have to counter them and keep them in the hospital against their will for their own sake, which can be hard because as healthcare workers, you're there to help the patients and they don't realize what you're doing and they're not on the same side. So overall, as you can tell, I really enjoyed this rotation and I feel so fortunate to have worked with wonderful residents and my staff. And I'm really going to miss it. The next rotation for me is internal medicine CTU, and I'm starting that tomorrow and it's for another 6 weeks. So please wish me luck and I'll see you guys in the next video. Bye!